healthcare research from the University of Michigan. He completed an internship and residency in internal medicine at Duke University Health System between 2017 and 2020, and he is an alumnus of the National Clinicians Scholars Program at the University of Michigan from 2020 to 2022. Dr. Ike is currently an assistant professor of medicine in the Division of Hospital Medicine, the Department of Medicine at Duke University School of Medicine, and he's also a faculty associate in the Trent Center for Bioethics, Humanities, and History of Medicine. He is a former participant and now a faculty member since 2023 of the Harvard Macy Institute's Art Museum-based Health Professionals Education Fellowship. He earned his Visual Thinking Strategies, VTS, work certification in 2024, and he currently serves as a VTS at Work coach. In his role as a faculty associate at the Trent Center, Dr. Ike serves as the director of the second-year medical student medical humanities curriculum for the Armstrong Scholars Program. He also serves as the co-director of the Duke Health System Internal Medicine Residency Program Art Museum-based curriculum for residents at the National Museum of Art on Duke's campus. Clinically, he works as a hospitalist at Duke University, where he treats patients with acute medical needs. Dr. I recently started a term here, Davidson College's Art Collection Advisory Committee, a group of mostly alums who advise the gallery on exhibitions, collections, and programs, and we hope that he will renew his term when he completes that. In his talk tonight, Dr. Ike will talk more about his work at the intersection of art and medicine, demonstrating how museums around the world are now being leveraged as innovative classrooms for developing the next generation of compassionate physician leaders. Before I turn it over, I want to recognize our support from the Kirk Jackson and Laura Grosch Gallery Endowment, the Baca Foundation Visiting Scholar and Artist Program, the Public Lectures Committee, and the McGaw Lecture Fund. And I also want to mention that if you're inspired after the talk, I hope you'll visit the gallery, which is open until 7 tonight. So now help me welcome J.D. Ike.
Thank you, everyone, for being here, and thank you, Flav, for the really generous introduction. I'm surprised you made it through it without a single blip, because there's a lot of alphabet soup in there when it comes to medical jargon and medical words. It's always a fantastic opportunity to be back on campus. I think today actually was the first time I ever went into the guest house, despite walking past it for 4 years on campus, and it's quite a treat. So the topic tonight is really going to be about how visual art specifically is finding its way into healthcare education at all levels. That is at the undergraduate level, like here in college, medical school, residency training, and kind of onwards into practicing clinicians. Kind of been
Fix the lights.
Fix the lights. Okay.
I thought I could do it from the back and not interrupt you, but I think we don't want them fully off, right?
Is that better? Okay.
Good mood lighting?
That works for me. And there'll be plenty of opportunity at the end to ask questions. All medical talks will tell you that I have no financial disclosures or no financial interests that I need to make you aware of that are impactful related to this talk. And like any good medical school talk, we're going to have a couple objectives for today. First, I want you guys to just understand what it takes to become a physician, a US-based physician, an MD in the United States. And then we're going to kind of explore the origins of how visual art found its way into medical education in the first place. And then the real chunk of the talk is going to be this third point here, is why is the museum such a unique space for engaging medical learners at all levels? And the roadmap of how we're going to get there is introducing medical education, the origins of art-based programming, and some of the emerging trends that took place really in the 2010s related to empathy, tolerance for ambiguity, openness to diversity, and things like that. And then we'll get a little bit more theoretical. Why visual art? Why is that such a unique medium to put in front of medical learners? And we'll talk about the state of play of health humanities education in the United States. And lastly, we'll kind of pivot to museum-based programming with some case studies. So how do you become a doctor in the US? Well, first you start with undergraduate studies. That's college, like here at Davidson. Ideally, it's 4 years. I put an asterisk next to it because every once in a while some people will carry it on a little bit further. My father was very adamant that the Davidson tuition needed to be paid in 4 years and then be done. Then you go to medical school, which in the official jargon is referred to as undergraduate medical education. This, for most students, is 4 years, with 2 years of classroom-based study, followed by 2 years of study that is largely clinical and based in hospitals and clinics. I put an asterisk plus here as well, where I teach at Duke. We have a lot of students taking an extra year, sometimes two, either for research or to gain additional degrees in public health, Masters of Business Administration, scientific master's research degrees, things of that nature. Once you've completed medical school, then you go into your residency. This is what people say when you're an intern or a resident. And this is in any number of subspecialties or fields. So this can be internal medicine, OBGYN, general surgery, dermatology. And once you kind of select your cohort, you're then in that program for anywhere from 3 to 7+ years. The 7+ years is really disciplines like cardiothoracic surgery or heart surgery or reconstructive plastic surgery, where people can spend upwards of 8, 9, 10 years of training. Once you've finished your residency, you have the option to become an attending in said discipline. So if you train like myself in internal medicine, I did 3 years of residency training and then could have become an attending, but I did take the pathway to become a fellow, where I was at the University of Michigan for 2 years doing additional work and research. But these fellowships that you think of are also considered graduate medical education and are in disciplines like cardiology, gastroenterology, endocrinology, or if you become an OBGYN, maybe you're doing gynecologic oncology. So it's additional subspecialty training before you become an attending and have completed your journey. And once you reach the attending level, we call that continuing medical education. So there is still programming that exists for you to continue learning throughout your career as a physician, as it never stops. And you continue to have to take your board exams roughly every 10 years for most major disciplines. In each phase, there's competencies. What do you have to learn? What do we want you to get out of it? And the pre-medical competencies, I think, are particularly relevant to this audience because this is what the American Association of Medical Colleges feels is important for students in college applying to medical school. And you'll notice that there's 3 main domains. There's professional competencies, there's scientific competencies, and there's thinking and reasoning competencies. And the takeaway from this slide is this is the most important thing that is emphasized, right? These cultural humility, empathy and compassion, communication, ability to work within a team. Are you oriented towards service? And the scientific competencies, learning about living systems and human behavior, while fundamental to being a physician, I found in my own practice is something that comes in the background. And these professional competencies are what often come to the forefront, and I think perhaps the benefit of a liberal arts education. We have similar competencies that are stressed in medical school and in residency, and these are the 6 domains that are stressed. Anything from professionalism, patient care and procedural skills, medical knowledge, some things that are self-explanatory, and some things that are perhaps a little bit harder to understand, like what does it mean to do interpersonal and communication skills? And we'll dive a bit more deeply into this point here when we do our case study, looking at some of the work that we're doing at Duke for our internal medicine residents. But first, I think it's important to step back and say, how did we even get to talking about art being in medicine? And this isn't an art history talk, so we're not going to talk about paintings from the 19th century or the 18th century of physicians practicing medicine. But the origins of putting art in front of medical students really dates to around the year 2001. And we'll go over a specific study, but they had a question. If I put a painting like this one in front of a group of medical students and we spend some time talking about it, analyzing it, dissecting it, are you going to be better able to describe something like this? Is there a direct link between looking at art and your observation skill in physical diagnosis of patients, where you're looking at people's bodies and trying to make deductions and inferences? And the first group to really do this was out of Yale, at the Yale Center for British Art, which you see down on the bottom left side of your screen. Jacqueline DeLev, Braverman, and her team essentially took a group of first-year medical students, so bright and cheery-eyed, and said, we wonder if fine art would improve their ability to diagnose patients. They do have a control group, so they split the class into 2 groups. One was just getting the standard physical diagnosis lectures. The other half was taken to the museum for sessions. And this was published as a very short, maybe 750-word letter to JAMA, which is considered one of the most important medical journals that exist besides the New England Journal of Medicine. And they said, hey, we created this rubric. And it turns out our students that went to the museum did better than the students who did when it came to diagnosing clinical images on a 10-point scale. So maybe there's some signal here. Maybe there's something that we need to look into. But around the same time, where visual knowledge is starting to gain traction, we're starting to see some other alarming trends in medical school. This is a systematic review. For those that aren't familiar with that level of evidence, that means that we reached a critical point in the year 2011 when this study was published, that we had over 18 studies exploring what happens to medical students' empathy throughout their 4 years of medical school. And what do we see? It was declining. Students came in caring for people, but they left calloused, kind of burned out, not necessarily seeing patients as human beings. And this paper proposed some mechanisms. This is really busy. What I want you to keep in mind are these bolded areas are kind of the definitive areas that were trackable in the literature, and these kind of grayed out boxes with the dashes or maybe some proposed mechanisms. But you see that clinical practice happens at a very vulnerable phase. You're a 23 or 24-year-old, you're bright-eyed, and all of a sudden you're exposed to people who are suffering an immense amount. You might be encountering people who are going things that you never thought were possible. People might die in front of you, and what does that do to you as a person? Similarly, you're overworked, right? Medical students were on average, when I went through, spending 75, 80 hours a week in the hospital, and then leaving the hospital to go home and study in preparation for exams, and this includes weekends. So your quality of life is low. You may be getting a little bit depressed, especially if you're at a New England school and there's no sunshine outside. And I wasn't, but thank goodness. And this has led to kind of a decline in empathy maybe in medical education. So that was one trend that perhaps we were noticing in the 2011s. And we had a similar trend that was published by Gail Geller and her team up at Hopkins, looking really at tolerance for ambiguity, openness to diversity, and also looking into empathy. You guys can come on in, come grab seats. It's totally fine, won't interrupt. And what Gail did, initially she published some studies around 2011, 2012, the same time that we see that empathy study. But she did something very interesting, and that is every matriculating student in medical school in the year 2013 and 2014 completes a survey. And then when they graduate, they complete another one. And in these surveys, sent to every medical student in the country, they measured 3 things: tolerance for ambiguity, using a psychometric scale, the interpersonal reactivity index, which was thought to be a marker for empathy, and then they used another metric to kind of assess the openness to diversity. And contrary to what they saw in the past is that students who came in with low tolerance for ambiguity at the beginning of medical school actually graduated and were perhaps a bit more tolerant. And maybe these were your students that, for the largest part of their career, they were only doing multiple choice tests where there was one right answer. And now all of a sudden they realize medicine kind of deals in the gray. And there's often multiple solutions to a single problem. But they also noticed that those that came in with lots of tolerance for ambiguity seemed to get worse. And that this correlated similarly to empathy and openness to diversity. So there is something that happens in those 4 years of medical school where we are changing fundamentally who we are as people and how we consider and look at the lives of others. And I think it's also important to recognize that all of this work is seated within the patient experience. How can we make patient care better? How can we interact with the public in a better way to improve health? And Health Affairs is one of the most important journals that looks at broad kind of public health and health-related trends. In this study, published in 2011, I hope you're catching on to a trend here. 2011 seems to be some sort of crux point when we're thinking about empathy. Sought to try to better clarify, what does compassionate care look like? Like, what does it look like when a doctor is treating you compassionately and caring for you? And so they came up with a list of many elements that were considered part of compassionate care. Now, for the sake of not having a slide that carries on for a long time, I've selected just a few. So, showing respect to you. Do they listen to you attentively? Does your physician gain trust when you're talking about sensitive things? And then they showed this survey to patients and to physicians. And this is the percentage of patients and physicians that gave it a 9 or a 10 out of 10 in level of importance. And you can see there's a high degree of concordance. For example, treat you as a person and not as a disease. 85% of patients think that is one of the most important things you can do. And we, as physicians, would largely agree with them. But what I love about this study is then they asked that same group of patients, how many of your physicians have met these elements that we consider to be compassionate care? And we see that it's pretty abysmal. Only 50% of patients felt that their physician was comfortable about discussing emotionally sensitive or psychologically sensitive topics with them. And that is something that we really have to do every day. Something that I do every day when I'm in the hospital. So there was something lacking within the medical education sphere to address these domains. And what you see is just an explosion of arts-based studies trying to address these domains. Here we have one talking about observation skill again. We have another talking about affective and cognitive empathy. We have another one talking about implicit bias. How do we make ourselves aware of bias using art and archaeology? Art is sanctuary. Our burnout levels are through the roof. How do we learn to reflect? How do we learn to handle uncertainty? How about resiliency? How do we make it through the tough training that lies ahead? And lastly, again, observation. So we start to see all of these studies kind of explode in popularity amongst medical schools across the country, trying to address these very real problems. But doing so in a kind of haphazard way. Everybody was just saying, well, I'm just going to try it. And then because it was a void of literature, you could largely publish what you were doing. Here's the curriculum that we used. Here's what our students felt about it. And we can talk about program evaluation later. But it was mostly what we call a Kirkpatrick level 1, asking students, how was that experience for you? What did you take away from being in the museum? Not further levels, like did we notice a change in the behavior of the student when they were interacting with patients? But I think it's important to step back. So we have all this kind of going on in the background, but I haven't necessarily told you, like, why is visual art important for medical training in the first place? And I think one of the first concepts, and this is kind of like the more theoretical, philosophical underpinnings of this work, is to introduce a few ideas. Elizabeth Gofford here is one of my partners at the Harvard Macy Foundation. We teach together in the museum-based fellowship, which I'll talk a little bit more about later. But she published a wonderful piece called The Third Thing. And it's this idea that art is a third thing. It's an intermediary that allows us to talk about difficult topics that we otherwise couldn't address directly. Do you want to talk about race in medicine? Do you want to talk about what it's like to care for an underserved transgender population? Well, if you talk about that directly, there's a lot of emotions, raw emotions that can come up with medical students and with patients. But if we use the art as a mediary to kind of explore that space, we're coming at it on the slant. We're not coming at it directly. And through that process, we're able to make new meaning. Additionally, Liz has written extensively about using art and objects, bringing them with you as an opportunity to open up to others. Everybody brings something that's meaningful to you, that tells something about your story. And then those people that might not want to share who their identity is, or what it's like to be a first-generation American, or what it's like to be the first person to go to college or medical school in their family, the art object can serve as a possibility for them to explore that. But there's a bit more of a philosophical underpinning here. In a paper published by Arno Kumagai, who was at the University of Michigan and is now in Toronto, he published in Academic Medicine this paper called Making Strange. And it was based largely on the work of Russian theorist Viktor Shklovsky. I apologize if I mispronounced his name. But he had this whole principle that, and I'll read this quote, it says, in order to return sensation to our limbs, in order to make us feel objects, in order to make a stone feel stony, man has been given the tool of art. The purpose of art, then, is to lead us to a knowledge of things through the organ of sight instead of through recognition, by estranging objects in complicating form. The device of art makes perception long and laborious. So in other words, it makes it strange. It's not easy to just look at something and come up with an answer. So if you're in a medical environment where the answer is chest pain plus left arm pain equals heart attack, and you just automatically go to that, what about when it looks different? How do I make that appear differently to you so that you can think of more things? And the goal here is really to incur what we call cognitive disequilibrium. The role for the art that we often use in these spaces is to make you slightly uncomfortable, to push you to a place where you didn't know that you could go, or that existed, in order to kind of dissociate and help you realize that problems are complex and need you to think about from multiple different angles. Arno followed this up in 2017, so that first Making Strange piece was published in the summer of 2017. In December, he wrote this, I think, very fantastically titled piece, Beyond Dr. Feelgood. He tells an anecdotal story. He was a speaker at Duke, so I got to talk to him about this. He heard medical students walking through the hallway and saying things like, did you hear, we got to go to Dr. Feelgood's class this afternoon, because that was what the humanities session was referred to as. But he thought it was important to kind of highlight some of the ways in which the arts can really serve a purpose in medical school. And we have 5 items here: disruption, reflection and pause, sociological and historical, examination, oral imagination, and human expression. Now, I've picked works of art that highlight these principles that I've used in my own teaching for the next kind of didactic year. So let's talk about disruption and reflection and pause. This is a piece by Felix Gonzalez Torres, kind of a conceptual artist practicing in the 1990s before he passed with AIDS. The piece is a light bulb, 2 light bulbs, hung to a nail on the wall in a gallery. And you ask the students, find a work of art that you don't understand. It just doesn't make sense to you. We don't allow them to read the placards on the wall. But a lot of students will come to this piece. This doesn't make sense. We just have 2 light bulbs nailed to a wall. But when you start to explore the story of the piece, that Felix Gonzalez Torres dedicated this to his partner, and both of them had HIV and AIDS. And he was making it as a metaphor for their relationship, and that we don't know which light bulb will burn out first, or when. And when this piece, when the light bulb burns out, it is not to be replaced. So what starts as a piece of conceptual art then becomes a metaphor for talking about grief and loss and disease, and the possibilities of relating to populations that you might not understand. I'm not a gay man, nor do I have a debilitating disease like HIV and AIDS, but I do have someone that I love and someone that loves me. And I can understand what it might feel like to lose that person, or to have some sort of expiration date that is beyond my knowledge, that might be imminent. It could be related to a cancer patient or a loved one. So using the arts as a mediator to kind of disrupt how we think about problems and to cause us to pause. What about sociologic and historic examination? Purposely chose a piece here from Nicholas Thomas, which you guys will all know with the piece on campus that was unveiled this past fall. But this hangs in the North Carolina Museum of Art in Raleigh, one of the pieces that I've used with some of my other students. In this piece, Thomas is asking us to really think about how the black male body has been viewed historically and culturally by juxtaposing a football player and a cotton picker. How are we talking about male bodies, especially the black male body in this day and age, as a force of economic productivity, be it through an NFL-owned football player or through references to the plantation and cotton. So how do we talk about race in medicine? Traditionally, it's just been a PowerPoint of statistics about how certain populations have worse outcomes than others. But that seems to me to miss the point of the deeper conversations about how do we understand justice within healthcare. What is a moral imagination? Medical school, residency training, these are times when you're going to care for a dying patient, when you're going to be present during the last breath, when you're going to pronounce someone dead for the first time. What is that going to feel like? If you've never done it before and you're just walking in blind, you might be wholly unprepared. But if we spend time, as I do with my students in my second-year medical student curriculum, exploring this painting by Edward Monk, which captures the moment when his sister died of tuberculosis, pictured here in the chair, we can start to imagine, what is it like to walk into this room, to meet those staring eyes? What do you say? And we'll do reflective writing exercises and other things paired with this visual art activity to help them begin to explore that space and to understand what does it mean to be at the bedside of a dying patient, and when that patient dies, what does it mean to be there for their family? What do you say? How do you comfort someone? And lastly, it can be a tool for emotional expression. This is a piece by Richard Serra, monumental in size, constructed out of iron, just a monument to sorrow and sadness. Doctors like to repress emotions. We don't like to talk about them. We're type A, we're analytical, we're left brain. And we don't give ourselves the opportunity to step back and reflect on wins, on losses. And the arts offer us an opportunity for deeper reflection. We'll talk a little bit about how we're doing that with our medicine residents. But before telling you what we're doing with the medicine residents, I think it's important to tell you what's happening in humanities education right now. Because we talked about why the arts are important. We talked about those studies in the 2010s that were really laying the foundation for visual art and other forms of humanities practice for medical education. But where are we now? So starting in 2018, we started to recognize that maybe the arts and sciences aren't too different. And the National Academies of Science, Engineering, and Medicine in 2018 puts out a report called Branches from the Same Tree. And what this report called for was essentially saying, medicine and art shouldn't be seen as disparate fields, but they're intertwined. They're branches from the same tree, and we need to think about them in conjunction with one another. And at the same time, the World Health Organization, Daisy Frankfurt, who will be a speaker at an art symposium in Boston, which I'll mention at the end of the talk, this coming September, put out a synthesis report saying there's all this data to suggest that adults and children interacting with the arts broadly, visual art, theater, literature, music, are having better health outcomes than those who do not, a better connection with their community. They live longer, they have lower rates of dementia. And recognizing that this is something that really needs to be looked at at a public health level. But what's happening in the medical education space? So the big bad AAMC, the Association of American Medical Colleges, kind of funds and publishes 3 reports around 2020 and 2021. The first is the FRAHME report, and that's accompanied by a scoping review and something called the PRISM model. So the FRAHME report was a monograph. So the AAMC has published some very large monographs in the past, maybe one every 3 to 5 years maximum. So this one was called The Fundamental Role of the Arts and Humanities for Medical Education, FRAHME. If you also haven't picked up on that, medicine loves acronyms. We can come up with an acronym for literally anything. Clinical trials are the worst. But they were calling for the integration of humanities at every level of medical training, starting at undergraduate, college, undergraduate medical education, medical school, residency training, and then continuing on into professional education and continuing education for practicing clinicians. And you'll notice here that Liz Goffberg, the second author, is also someone that I referenced earlier who drafted the third thing article that we mentioned. And the scoping review that accompanied this FRAHME report was done by Tracy Moniz and her team, and it looked at, in the year 2020, what have we done with the humanities in this past 12 years? And you'll see that we have around, I think it's 800 or so studies that were largely summarized, but they were impoverished due to lack of compartmentalization, lack of theory, missing perspectives, and it was a lot of just kind of like we talked about earlier. I did something, I wrote up my curriculum, I submitted it to a journal, and I got it published. We haven't really built knowledge across subfields. We haven't really engaged in any substantial theory, educational theory, or medical education theory, and we're missing the voices of artists and practitioners in this process, right? It's largely doctors like myself who have a humanities background or interest trying to develop programming. But how do we bring in people from across disciplines? How do we bring in the medical anthropologists? How do we bring in the practicing visual artists to help us in that process? And so Tracy and her team, with whom we're working on a separate article at this time, published something called the PRISM model. And this was on a AAMC last page of their journal called Academic Medicine. And they proposed 4 things, 4 kind of domains that humanities interventions within medical school and residency should think about. Skill mastery, perspective taking, personal insight, and social advocacy. So if you're thinking you want to use the arts, you might want to fit it within one of these broader domains so that we can create a more cohesive pedagogy and literature surrounding humanities interventions. Skill mastery is perhaps one that's very obvious. The observation skill studies that we talked about earlier. I want to study observation, so I'm going to fit within this green box here, and I'm going to design an intervention that focuses on learning how to better visually diagnose dermatologic conditions in the clinic. It gets a little fuzzier when we start thinking about some of these other things. Well, how am I going to use art to do perspective taking? How do I learn to put myself in someone else's shoes? How do I better tolerate ambiguity? Or maybe I want to work in this advocacy sphere. How am I going to use the arts and humanities to create practicing clinicians that care about justice for the populations that they're indebted to serve? And that leads me to museum-based education and why the museum has emerged as a really interesting playground and learning lab for these interventions to take place. And most of my work is done at the National Museum of Art on Duke campus, the North Carolina Museum of Art in Raleigh, and then through my teaching with the Harvard Macy Foundation in Boston, we teach at all the Boston museums. We teach at the MFA, the Museum of Fine Arts, we teach at Isabella Stewart Gardner, and we also teach at the Harvard Art Museum. Sometimes we go to Mass Art, just depends. But what is museum-based education? Well, it's really collaborative. It is this emerging space where clinicians, medical educators, museum professionals, and artists are really working together to try to design programming and interventions that are attuned to the specific needs of a medical audience. And there's a variety of methods, of which I will show you. And there have been emerging novel and interdisciplinary training programs to try to get people the experience necessary to learn how to do this work. 2 of those programs, the 2 most well-known that currently exist, are all seated within the Harvard Medical School, specifically the Harvard Macy Institute, which is a subfield of professional programs for practicing clinicians. One is the Art Museum Health-Based Education Fellowship. This is the one I was so impressed that you could say correctly, because we get it wrong every time. This program started in 2019, and I was a fellow from 2021 to 2022. It is a year-long program that includes 2 kind of 3 to 4 day retreats in Boston, which is then flanked by a year-long curriculum where you design an intervention. And you go through a significant amount of background prep work, training, and what it means to evaluate and create curricula and think about it more broadly. And I've served as a faculty member with this program since 2023. And then in more recent years, in 2024, they launched Training Our Eyes, Minds, and Hearts, Visual Thinking Strategies for Healthcare Professionals. And we're going to talk a little bit more about BTS here in a moment. But just know that this whole museum-based space is really starting to grow to the point where we have large organizations creating programs that cost thousands of dollars that are drawing clinicians from all over the world interested in spending. For this program here, it's twice a month, meeting 5 hours, so 10 hours a month for 6 months. So these are not light programs where you show up for a single seminar session. They're intensive, they're expected to create someone on the other end who can then take a group of students into the museum to teach. And this has been accompanied by some significant research on all these things that we can do within the museum setting. But instead of having you read this busy slide, we're going to do a case study. And this is exactly what happened at Duke for our internal medicine residents. It's a 3-year residency. And the program came to myself and my mentee, Belk, who's a current pulmonary and critical care medicine fellow. And they said they wanted to do something in the art museum. We saw other medical schools were doing it, and we also kind of approached them and said, hey, we think you might really have a need here. So when a group comes to me, there's always some questions that I ask. How much time are you going to give me? How many people am I going to bring into the museum? What are the specific objectives or needs of your learners that you've identified that you're hoping we can address in the museum space? And what's the budget? So they told me, you got 3 to 4 hours, twice a year. So you're going to get 2 afternoons protected. The residents are going to be there. They're not going to have any other clinical responsibilities. So maybe about 14 will come. And they told me that they're going to be the 2nd-year residents, which is critical because they're no longer interns. Intern year, you kind of just show up. You've got a senior resident above you, you've got an attending above you. You're kind of just like doing the scut work. You're writing all the notes, you're putting in all the med orders, you're ordering the labs, but you're not necessarily always making the higher level decisions about the plans of care. But the 2nd year is really when you've kind of stretched from that like kind of under-level role to leading a team. Now the interns are below you, and you're responsible for helping make the treatment plan. There's a lot of leadership and responsibility. Our 2nd-year residence is also the time when you're entering the ICUs for the first time. That's when you start going into a single shift, and you might have 3 patients die in the 8 beds that are assigned to you within 24 hours. And for a lot of our residents that were in COVID, that might happen every time they went to work. They would have 2 or 3 patients die. And then they would come back 2 days later for a 30-hour shift, and the same thing would happen again. So this is a group that's been through a lot, and they're kind of at a crux point. And I said, well then, what are your objectives and needs for these residents? And being a resident myself not too long ago, I kind of had an idea what they were going to say, but they really wanted to focus on communication, well-being, and their professional development. How are they creating their identities as practicing healthcare professionals? What is that process looking like? And lastly, what's the budget? I put 500 because I wanted to put a number, but they really said we don't have a budget. We want you to do this work for free. And that's a separate topic, but thankfully I have fantastic partners at the National Museum, and part of their academic mission is supporting the programming of the University of Mars, so I did not necessarily have to pay them. We eventually got a grant, and we used some of that for food and other things, but residencies are usually strapped for money. And how do we also fit this into the broader spectrum of like, how does art wind up taking up a half day of a resident's limited time when they could otherwise be getting a lecture on how to manage high blood pressure? And it goes back to those competencies that we talked about. And you can see one here that ACGME says that interpersonal communication skills is required to graduate residency. And you say, how granular does it get? My answer, it gets very granular. You see it goes all the way to G, and there's a few more after that for each one of these competencies. So, point being, you can always link it back to something that an accrediting organization finds to be important, that the AAMC through the FRAHME report finds to be important. So there is space for this in curricula to advocate for it. But what are we going to do when we actually get in the museum? And I'll point out here, this is Belk. She's my mentee who helped kind of create the national curriculum. She was a medical student at UVA, and her mother was a PhD art historian, and I believe worked at the FRAHME Museum of Art at UVA. So she also had a long-standing art history interest. So we all try to find each other in the medical world when we have an arts background. But what are we going to do in the museum for this session, this 4-hour session about professional identity, communication, community building, and well-being? And here I have a picture of Ellen, who's Ellen Raymond at the National Museum. She has a PhD in art history and also works as a museum educator. And she and I always try to come up with new and engaging content that I'm bringing back from my work in Boston. And so this is what an afternoon might look like. We're going to do a poem. We're going to have a warm-up activity. We're going to do VTS. We're going to do a personal responses tour. We'll do some drawing exercises, some active play in the museum space, and then we're going to do a closing activity. But I'm going to walk you through each one of these because I think they show you the cadence and the rhythm of the afternoon. So what type of poem might we open with? I often turn to this, which isn't really a poem, it's technically a blessing by John O'Donohue, who was a Celtic philosopher, he was a poet, he was a clergyman, he had many different hats. He was like a true Renaissance man who passed away unexpectedly in his sleep and has some great interviews on Krista Tippett's On Being podcast if you ever have time to listen. But you can see this poem here talks about be awakened to the mystery of being here, enter the quiet immensity of your presence. We kind of set the tone at the beginning of the session that this is going to be an opportunity to step back, to reflect, to ask yourself about bigger questions of why I'm here, why am I doing what I'm doing. And your pager's not going to go off. You have no other obligations than to be here in community with each other. And what we will talk about and experience in the museum stays in the museum, but the experiences and lessons leave ownership. So after we kind of read this poem, I can tell it's going to be a quiet group. I might go around the room and say, I want everyone to give me one word or phrase that comes to mind after we've read this poem. And some people might say peace or dignity or a calming breath. And that also tells them that this is going to be participatory. You can't just sit back. I'm not here to lecture you in the museum. This is not a docent-led tour. This is not me telling you what to think about the art. We're using the art as an intermediary to talk about experiences. And with that, we'll go into something fun, kind of a warm-up activity. And the way that I do this is I give every student a stack of Post-it notes. And I said, I'm going to give you 60 seconds. And I want you to write one aspect of your identity on each Post-it note and just put it out on the table in front of you. This can be things like first-generation college student, new parent, coffee lover, cat dad, whatever you want to put on there that you think is critical to your identity. But don't tell them what I'm going to do next. And after they spend a minute, have all these Post-it notes in front of them, I say, okay, now you got to stick them on yourself. You're going to cover it. They don't do this much. But this is the only image I could find online. We don't take a lot of pictures during this exercise. And they'll affix the Post-it notes to their body. And then I'll ask them to kind of wander around the room for 30 seconds. And it's kind of like musical chairs. And I'll say, stop. Pair up with the person next to you. And you'll look at the person next to you and you'll read their Post-it notes and you'll ask them about one. And they'll have a minute to share. And then you'll switch. And we'll do this 3-4 times, depending on the size of your group. So the entirety of the activity is maybe only 8 to 10 minutes long. And then we'll debrief. What did that activity ask of you? What was it like to participate in that? And you'll be surprised that these residents that have worked shoulder to shoulder in the hospital are learning things about the people that they've worked shoulder to shoulder with on these 12, 18, 24-hour shifts that they never knew. I didn't know you were a chef and an avid cook and a home baker. Right? So it gets into like, who are these people that you're working with and who are you as yourself? Who do you see yourself as in this beyond just doctor? No one writes doctor because everyone there's a doctor. So who are you beyond that? And who do you want to bring when you show up to work to take care of patients? And what might your patients be showing up with? Are there parts of their identity that you need to ask about? So this sets the stage as to kind of what the afternoon is going to look like. And then we go look at a work of art. We go into the gallery space. And I tell them they only need to bring their experiences and their observations. I tell them they don't need to bring any art history experience. I'm not asking you to analyze the art. No formal training is required. Because these are a lot of people who have never taken an art course in their life. Maybe they don't even go to a museum. Maybe they don't feel welcome in museums. They've been seen as spaces where my culture, my people are not represented. They're institutions of power that I just don't feel comfortable in. So I tell them, we're just going to show up. And we're going to have some interpretive conversations around art. We're going to use a method called VTS, or Visual Thinking Strategies, which was developed by Philip Yenowine and Abigail Hausen, who are an art educator and a cognitive psychologist, really kind of working with elementary age kids initially, but has since been expanded to all ages, and trying to get people to engage more fully with the work of art. And it's predicated on 3 really simple questions. And facilitators in VTS have to go through extensive training. Remember that course I mentioned? We do 6 months, 10 hours a month. At the end of that, you can have the opportunity to apply for certification, but you still have to submit multiple videos of you facilitating these conversations within a museum setting and then be accredited by an organization. But what I will ask when we do VTS is, what's going on in this picture? Somebody will raise their hand. And then as a facilitator, I'll paraphrase what I've heard, reflect it back to them, maybe using some new or conditional language. For you, this might be. This could be a picture of blank. And then I'll ask them a pointed question. What do you see that makes you say that this figure is sad? And they have to root their observation in the evidence. Well, I think they're sad because, their eyes are a little downcast and maybe I'm catching the hint of a tear. And then we always open it up with question 3. What more can we find? Inviting others to share their observations. And we know through an extensive body of research that BTS has several benefits, especially for medical learners. Over time, observations become more detailed. Basic inferences are made using evidence. You don't just go and look at a patient and say, oh, they look pretty sick. What do you see that makes you say that they're sick? Like, what did you notice? Was it their heart rate that you saw? Was it that they were sweating and had a look of fear in their face? You also, when you're doing BTS with a group of 10 to 12 people, you have to listen to other people's perspectives. And let me tell you, when you get a different group that has some interns, some higher level residents, some attendings, maybe even you bring a nurse in or a physical therapist, and you neutralize them with art, where no one is an expert, as opposed to in hospitals where everything is hierarchical and the attending in the white coat is supposed to know all. It levels the playing field, and you realize that everyone has observations that are important and can contribute to the understanding of the whole. And because of that, you're considering multiple perspectives. You're holding them as plausible. And you're revising maybe your initial conclusion. I think this is an upset person. Actually, since I said that, I think this person might actually be happy. And it improves your tolerance for ambiguity, and that repeated practice eventually leads to a habitual behavior. This has become integral to my practice of bedside medicine. I will paraphrase back what a patient has said to me, or I will verbalize what I'm seeing. When I started to ask you about your cancer screening, you seem to get really anxious. What did you experience that made you so anxious when I asked that question? And maybe it's because their loved one or their parent was diagnosed with colon cancer. They're so scared of getting a colonoscopy that they just put it off. And that's an opportunity for me to maybe make a meaningful difference in their health outcomes. But what kinds of images do we use for BTS? Because you can't use just anything. It can't be literal. It has to have just the right amount of ambiguity. So this is the type of picture that we might use in a BTS conversation. What is going on in this picture? And you might get any number of observations. And a single BTS conversation for an image like this one lasts about 30 minutes. I challenge you to think of the last time you were in a museum and spent 30 minutes with a single work of art. And once we're done having a conversation, I don't tell them the artist. I don't tell them what it's about. I thank them for their observations. And oftentimes when I'm teaching the same piece, I'll say, I've taught this in multiple groups, and every time I come away with something new or something that I hadn't considered before. And then after every museum exercise, we pull back. What did that activity ask of you? What was it like for you? How did that relate to clinical medicine? And you will be surprised at the things that come out. I never really thought about what happens when I sit with something for longer and move beyond my first or second impression. Well, this makes me think of when I'm working up a patient for something that really doesn't make sense, and how I have to go back and revise and think through multiple things. Or, how valuable it is to get someone else's perspective, or get it with a fresh sensor, a fresh set of fresh eyes. After a visual thinking strategies conversation, we might do something called a personal responses score. Or this might be flip-flopped, and we would do this before the BTS conversation. This was developed by Ray Williams, who's an art educator at the Bland Museum of Art in Austin, Texas. He's also one of the core faculty members of the Art Museum Base Fellowship with the Harvard Macy program. And this activity is very simple. You see there's a basket over there. So I, as a facilitator, will create a series of prompts, put them in the basket, and I'll ask everybody to draw a prompt out. And I'll give them a gallery or a set of rooms if the museum is large and say, you have to find a work of art that responds to your prompt. I'm going to give you 15 minutes. I encourage you to spend 7 minutes maybe wandering. And then once you've found that piece that seems to grab you or maybe respond to your prompt, I want you to sit and look at it for the next 5 to 7 minutes and just think about how it responds to your prompt. And then we'll come back together as a group and we'll go on a tour. And everybody will have an opportunity to share their reflection. And that's what we're doing here with our medicine residents at the National Museum of Art. And I wanted to give you guys some examples of what these prompts can look like. And you can tailor them to whatever your need is at the time. So if we're doing a session primarily identity focused, which I do for some of the Duke undergraduate students when I teach them a summer program, it might be find a work of art that encompasses an aspect of your identity. Why did you select this work? So somebody will have to go around and pick something that maybe represents a piece of themselves. Or if we're talking about well-being, think about a low point that you've had as a resident over the past 3 months. I want you to find a work of art that you wish that you could share with your past self, that you could share with yourself when you wrote that low point. Let's see what you find. Or maybe just, if you're giving everybody the same prompt, maybe you choose one like the last one here. Find a work of art that relates to your current life as a resident. And I will find when people have the 1 minute or so that we give them to share in front of their work of art, and we don't necessarily have to make it a conversation. It's usually just that person sharing, and we thank them for their sharing and go on to the next one. We've had tears, we've had topics come up, and this gets at the goals and objectives of the session that we're charged with by the residency. We want to build community. We want to have empathic, thoughtful positions that are able to reflect. So when somebody is sharing a really dark moment, maybe they made an error that led to a bad outcome for a patient, they hadn't even thought about it or had the opportunity to talk about it, and now this art object, this third thing, like Liz Goldberg introduced us to, is giving them the opportunity to share in a safe environment amongst their peers an experience that they think was really relevant, and how that experience is embodied in the work of art. So it is not necessarily them saying, well, this was a piece by Picasso. It is not, when I looked at this piece, this is what I felt. This is how it related to this prompt. And we often put the prompts on really pretty paper. We have some twine, and they get to keep them. We encourage them to take a picture of the art and to keep the prompt. Some people will put it on their pegboard at home. Others will keep it in their white coat pocket and think back on it 3 weeks, 3 months later. Because they go back to the museum, and they might revisit that piece and have a different experience the next time, or think about the positive experience that they had during the session. After this deep activity, we go lighter. I want to do something where they get to move and interact and draw. And so we might do a drawing exercise. And there's 2 drawing exercises that I have to show you about what these look like. But this one is a perspective taking exercise. So the image on the right is us teaching in the Museum of Fine Arts back in October. I'm kind of hiding in the background talking to Ray, who created the PRT. What we do in this activity is we put stools around the sculpture. And everyone gets a clipboard and a sketching pencil. Ideally, you have about 10 people for a work of art. And I'll say, I'm going to give you 60 seconds to just draw something from this perspective. When the timer's up, they have to put their work down in their stool and move 1 chair to the left. And they're going to do that until they get back to their original chair. And so they're going to draw from each individual perspective. And what's so important about this exercise is, 1, people have to be bad at something. Most of us are not expert at drawing. I remember as an art history major here, the most humbling thing I took was the studio art courses, especially sculpture with cord. It's like one of my worst grades to date. But I loved it and I learned a lot. But when we pull back from this activity, what people talk about is, what did it mean to look at something from different perspectives? What did it mean to pick up and start where someone else had left off? And how does that relate to clinical medicine? I'm assuming most of you guys in the audience are not doctors, but we have a lot of handoffs in medicine. My shift is usually from 7 in the morning till 5:30, 6 p.m. at night. I hand it off to one doctor who covers for 2 hours, who hands it off to another one, who hands it off to another one. So at the end of my week, I give my whole list of patients to someone else to care for in the hospital for the upcoming week. And so this exercise gives people a lot of opportunity to talk about, am I just continuing on what someone else has already done? Am I looking to add something new? Am I reinforcing what's already there? Am I trying to offer a new perspective or a new lens? So it kind of leads to these conversations a lot about handoff culture in medicine, about looking from different perspectives, and also just about doing something humbling, like trying to draw. And one of my colleagues says, I had a medical student who was doing this with a group of other residents, and every time they just drew the base. Every station they drew the base of the sculpture. And when they were reflecting, they were like, I kind of felt like that was my job as a med student. It's the one thing I could do. So I did it. I wasn't ready to order the medications or have the life and death conversation with the patient at this stage in my training. But I could draw that base. So I'm going to do it. I'm going to contribute to the whole. And those are important perspectives for other members of the team to hear. Or we might do a kind of more nuanced exercise called back-to-back drawing. We have our residents here on the right. These are our Harvard Macy fellows on the left, where you pair up people in pairs. And if Laia and I are working together, Laia's going to go into the gallery and choose a work of art that she wants to describe to me. And I'm going to have to draw it, but I can't look at it. So Laia will sit here and look at the work of art, and I'll be to her back with the pen and paper, and Liza's gonna have to describe what it looks like. And I'm gonna have to try my darndest to sketch it. And I can ask questions, but I can't look until the end. But we also get to switch. So if I chose a really hard piece, I can go pick something really, really hard to make her try to draw next. But the pullback from this is, what is it like to communicate something that you're not, how do you interpret something that you're not directly seeing? You know, you look at a patient's chart, we document physical exams all the time. The heart sounds were like this, the lungs sounded like this, the abdomen felt like this. But if you're not the one directly feeling or touching the patient, you're interpreting it through text. But you don't necessarily always get to have that open-ended channel of communication. Oh, so you said it was kind of tender in the right upper quad. Like how tender? When you were moderately palpating, or was there so thinking about the types of language and how we communicate things, especially something uncomfortable like trying to describe art to someone who's trying to draw it, has a lot of corollaries to clinical medicine when you're trying to describe a problem or a set of symptoms. It just are ambiguous. They don't have a clear, definitive answer or plan. And then we'll maybe read a poem and we'll close, like we did here in the fall. And we'll all get in a circle. And like everything, the drawback and the pullback is really where the meaning making happens in these exercises. And we'll give everybody the opportunity to finish this phrase, and I noticed. And this will be something like, and I noticed what it was like to be out of the hospital for months and learn more about my peers. And it gives everyone there, including the skeptics, because this is a required curriculum, so this just isn't the people who are like, I love museums, and I love medicine, I'm going. This is the people who are like, I don't know why you were making me go to the art museum. I need to be studying for the boards and doing more review of antibiotics. But this type of activity forces everyone to kind of have the opportunity to verbalize something that they're taking away from that experience in the gallery. And it can be simple. What it was like to just have an afternoon not taking care of patients. Or what it was like to reflect on a tough experience that I've had that I haven't had time to think about yet. And those are often the take-home points that I can't create. That's the meaning that you created for yourself in the gallery space. And I know we're coming up at the end of my hour, so we'll skip the few more examples I have about how we used art and conclude with kind of a quote and a poem per se. This book here on doctoring used to be given to every entering medical student in the United States throughout a large portion of the 90s. And it was called On Doctoring. It's paid for by the Robert Wood Johnson Foundation. It was curated by Richard Reynolds, John Stone, and you'll see Lois Nixon there. John Stone was a cardiologist at Emory, where I went to medical school. Lois Nixon and I worked at the University of South Florida and came on an Italy study abroad medical humanities trip that we did when I was a medical student and serving as a TA. But they opened this book, which is a collection of poems and essays and stories, not by physicians, although there are some physician authors in this book, but largely by artists, by writers. And they say, of course, one need not be trained in medicine in order to make cogent and crucial observations about what it is to be sick and vulnerable, to witness and record the isolation and alienation that eventually comes to all of us. Finally, we are all patients. And I think I want to conclude with an excerpt for you guys of a poem by John Stone. He unfortunately passed in 2008. And I can share a really wonderful article he wrote about taking care of Flannery O'Connor and her lupus when she had pericardial effusion as a result of fluid around the heart from lupus. He gave a poem called Gaudium Spigatur to the graduating class at Emory Medical School. This is a small section. This poem is very long. If I read it to you in its entirety, it would take about 10 minutes. But it harkens back to this kind of charge, which is usually followed Gaudium Spigatur, de brevitate vitae. I don't speak very good Latin, but it's all about the shortness of life. And it means to let us rejoice while we are young, after a pleasant youth, after a troublesome old age, the earth will have us. So it's typically this rejoiceful graduation song that has a little bit of a memento mori or maker's death. But in the middle of this long poem, he says, for there will be hard data, and they will be hard to understand. But the trivial will trap you, and the important escape you. For the committee will be unable to resolve the question. There will be the arts, and some will call them soft data, whereas in fact, they are the hard data by which our lives are lived. For you can be trained, for everyone comes to the arts too late. For you can be trained to listen only for the oboe out of the whole orchestra. For you may need to strain to hear the voice of the patient in the memory of his crime. For you will learn to see most acutely out of the corner of your eye to hear best with your inner ear. So with that, I'll plug the Bridging Visual Arts and Healthcare Symposium this September in Austin. The registration is now open if you're interested in engaging with the breadth of health humanities educators across the spectrum in a 3-day intensive conference. We'll be presenting our work that we're doing at Duke. And I think we only have 5 minutes. I'm sorry that I ran so forever, but I would welcome any questions that you guys have.